Okay, so again, welcome to this section. This session, it's this tutorial is basically for candidates preparing for the MDCN exam, and perhaps those that have other international exams to also write like PLAB and co. But the emphasis again is for those preparing for the MDCN exam. Now, we have various subspecialty that we'll be dealing with in a couple of months. This include the 4 core specialties of medicine. This include internal medicine, pediatrics, O&G, and surgery. We'll also be including community medicine in the course of this discourse as we progress, and then radiology, ophthalmology, as we go along the way. Now, all of these will be anchored majorly by senior registrar. In some instances, we may need some consultants, especially for the biostatistics angle, to come in to help give lectures in that regard. Having said so, there's a timetable which is in the MDCN forum. Today, right at this moment, we're supposed to be having O&G facilitator having to present today, but for some issue, he's on call, and then he has a case he has to handle right back now. Hence, my own topic will be coming up to cover for that time that he will be unavoidably absent. Now, I will be discussing shock today. Now, shock cut across all specialty, be it medicine, be it pediatrics, be it O&G, and be it surgery. And then there's no how we bring question for you, either for the MDCN or the PLAB exam, that you're not going to see shock. But it's not going to come out classically like this is shock. They come out as a question in the form like you should be able to identify that this question is talking about shock. And then from there, if you're able to identify that this question is talking about shock, you could factor the answer out of it. Or you could come out straightforward, like you give a clinical scenario. And then if you cannot hear me, please signify your.
So where's the pen?
Sorry? Okay, it will also come out in the form whereby they give clinical scenario, and then they will ask you directly what type of shock it is. But commonly, it's going to come in the form whereby they give a scenario, they paint a scenario for you. You should be able to identify the type of shock it is, and then it's when you're able to identify the type of shock that they are dealing with, you can be able to answer the question. That's how commonly this topic comes out. And if you're able to understand that this is how the question comes out, you notice that many of your questions, if you're preparing for PLAB or preparing for USMLE, you're preparing for the MDCN exam, you know that some of your surgical questions actually are talking about shock. Having said that, this PowerPoint primarily was not prepared for this topic, for this class. Hence, you do have some information that may not be necessary. When I get to those places, I'm going to identify them and skip them so that you don't pay emphasis to those extra information that may not be necessary for you.
What about pen?
Sorry? Could you could just drop whatever you want to say on the chat box? Maybe I could just read them if you have anything to say. So having said that, we could go ahead. I guess you are seeing my slide. Now, let me define, there's a definition of shock, which if you're writing an exam in Nigeria, particularly the MDCN exam, you should be familiar with. And this definition is definition by Bidu and Baja. And it's the shock that most of your examiners are interested in. Is that definition of shock that they're interested in. And shock is defined as the clinical manifestation of failure of cellular function, which primarily do occur as a result of inadequate tissue perfusion and consequent cellular hypoxia. This usually will result from reduction in effective circulatory blood volume. What does this simply tell us? It tells us that shock is a clinical state first. A state that you can make diagnosis of by observing the patient, either by looking at the patient in combination with feeling the patient and then with laboratory investigation. And this clinical state occurs as a result of deficient blood flow to the cells. And once there's deficient blood flow to the cells, what normally happens? What does blood do to the cells? It helps to move nutrient to the cell, particularly oxygen, and then moves waste product of metabolisms, particularly carbon dioxide and coal, out of the cells. So the blood filled with oxygen and nutrient moves to the cell. There's an exchange, and then the blood moves to the lungs, onto the kidney. As moving out from the cells, taking away the metabolic products from the cells and giving themselves nutrient necessary for its survival. But in shock, that pathway for which blood flows and that exchange that takes place is affected. So when that pathway is affected, whereby blood flows adequately and there's exchange of nutrients and waste products, once this pathway is affected, we say shock has occurred. And commonly, that this pathway is affected does not mean that the blood is totally finished on the patient. The patient still has blood, but the amount or the flow, the amount of blood required for that exchange is low, or the flow rate is inadequate. Hence, they will say shock has occurred. So again, this explains the definition. Again, for the purpose of reciting this definition, again, this definition is a song in surgery. Shock is defined as a clinical manifestation of failure of cellular function due to inadequate tissue perfusion and consequent cellular hypoxia resulting from a reduction of effective circulatory blood volume. That paragraph is a song in surgery. And I've just explained what that paragraph simply means. Sum total explains everything about shock. Having said that, this epidemiology, you don't need it. It's just giving you an idea of how prevalent shock is in the US, in Kenya, and even in Nigeria. Now again, shock can be classified basically into 4 types of shock. We have the hypovolemic shock, we have the cardiogenic shock, we have the distributive shock, and we have the obstructive shock. Please don't worry yourself about the traumatic shock. That is not necessary in your level. If you have any question, you could ask. You could also drop it in the forum also too. Again, for hypovolemic shock simply means that the blood volume is low. And commonly, low blood volume can occur from bleeding, what we call hemorrhage, can occur from vomiting, can occur from not just vomiting, severe vomiting. It can also occur from severe diarrhea. It can also occur from third place losses, someone that's having accumulation of fluid in the abdominal cavity. For instance, someone that has typhoid. Shock can occur from these instances. But the common type of shock you will see in your exam is a hemorrhagic shock. Now, there are 4 stages of hemorrhagic shock. This particular stage, this is how it's going to come out. If it ever comes out in your exam, this is how it's going to come out in your exam. They would give you a clinical scenario. They give you a scenario whereby they will say the patient had an accident or had a cut somewhere in the body and was bleeding. However, the patient noted the parameters of the patient was noted to be this. The pulse rate was noted to be within 100 and 120. Or they may not tell 100 and 120, they may just put one value that falls within 100 and 120. They may put it at 110. we could just tell you again, the BP is within, they'll put the BP that falls within 100 and 120 again. The systolic rather. We could just say that the BP is 100. Right? We could also give a urine output that's within 20 and 25. We just give you maybe 23 mils per hour. Again, they may not give you all these parameters. They may just give you 2 parameters. They also give you a respiratory rate that falls, they will say respiratory rate is 22. That falls within 20 and 30. So we just say 22. Again, like I told them, we will not give you the entire parameter. We just give you 2 of the parameters, the pulse rate and the BP. That's commonly what the parameter will give you. Once they give you this parameter, they may not ask you what amount of blood has the patient lost. I've seen this question before. With those preparing for foreign exam, I've seen this. Maybe MDCN may have come or it will come subsequently. Somehow, someday, you ask you what amount of blood has been lost for this patient. You'll be wondering, they didn't give you blood volume. How do you know? But they give you parameter that you use to identify it. Now, if they tell you these parameters, any 2 of these parameters, they are telling that the patient is in stage 1 shock. Again, the blood volume for an adult, again, we'll tell you that the patient is an adult anyway. Maybe they just give you a range, a 40-year-old man, that gives an either as an adult or a 40-year-old woman. When they give you the age range, you know the blood volume for that age is 5 liters. And the parameters that they just give you is parameter for stage 1 shock. So what you just do is say 15 over 100 times 5,000, and you will see the value there inside your answer. Are we communicating? Please, I want us to be talking. Let me be sure.
Hello.
Doc, sorry, 15 over 100 times what? 5,000?
Yes.
Okay, to get like stage 1, for example, if it's
Yes,
15%.
exactly. So they just tell you, they give you parameters and they'll tell you how much blood has the patient lost.
Okay.
You understand? But you'll be surprised that they didn't give you blood volume. How come they're asking how much blood? But this is exactly what they want you to calculate.
Sorry, can you please go over it again, because I don't really understand what you just said. You said that it is 15 over 100 times 5,000.
Yeah.
So like, what is 15? What is 100? What is the 5,000?
The 15 is 15%. That's 15
Okay.
over 100, 15%.
Okay. And the 5,000?
Is the blood volume.
The blood volume.
Yep.
Okay, but then like, do we use it in every scenario, or it's just a particular scenario that we can use this?
I've just given a particular question that this scenario can come in from. I can give you that on that scenario again. But then, before I answer this your question, let me just hold on to your question, please.
Okay.
You ask me when I get to stage 4. I want to give you the parameters for stage 1, stage 2, stage 3, stage 4. Right?
Okay.
When I give you the parameters, we can then answer your question.
Okay.
Okay.
Yes.
Okay, for stage 2, the parameters you look at for stage 2, but the question will come out that patient lost blood, this, maybe had road traffic accident, was bleeding, the bleeding was arrested, then do not tell you the pulse rates, right? Tell the pulse rate is 120, the pulse rate, the tell is maybe 130. The range for stage 2 pulse rate is within 120 and 140. For stage 1 is within 100 and 120. Are we okay?
Yes.
Again, for stage 1 is within 100 and 120, right? For stage 2 is within 120 and 140. For stage 3 is within 140 and 160. For stage 4 is greater than 160. Are we communicating? Are we communicating?
Yes, yes.
Okay, so for the pulse rate alone can guide you in making your decision. So we could just give a case scenario: patient had an injury, trauma, this, bled, and then the pulse rate was, we could just say 110 or 115. You know that's stage 1. We just said the pulse rate is 138, 134. You know that's stage 2. We just said the pulse rate is 156. You know that's stage 3. We just said the pulse rate is 174. You know that's stage 4. Right? Yeah, with me, Abby?
Yes.
So,
Yes.
so that's one parameter they can give you, pulse rate. The other parameter they can give is the BP. So for stage 1, the BP is usually within 120 and 100. The systolic BP, to be precise. For stage 2, it's within 180. Stage 3 within 80 and 60. For stage 4, it's less than 60. Are we communicating?
Yes, sir. Can you repeat that pulse rate?
Yes.
Again, the pulse rate is for the first stage is within 100 and 120. For stage 2 is within 120 and 140. For stage 3 is within 140 and 160, and then greater than 160. Are we communicating?
Yes, thank you, sir.
Okay. So they could give you the pulse rate. They could, again, I'll give you all the parameters, but obviously in your exam, they will not give you the entire parameters. They will give you at least 2 parameters.
Sir, please can you repeat the pulse rate and the systolic BP, please?
Okay. For the pulse rate, the pulse rate for the stage 1 is usually within 100 and 120. So they could just pick one particular value within this range and give to you. For stage 2 is within 120 and 140. They could just pick any value within this range and give to you. For stage 3, are we communicating? For stage 3 is within 140 and 160. For stage 4 is greater than 160. Are we communicating?
Yes.
Yes, sir.
Then for the BP, it's usually 120 to 100, 80 to 60. Sorry, within 120 to 100, 100 to 80, 80 to 60, less than 60.
Can I ask a question?
Okay, I'm with you.
The normal BP in an individual is around, let me say, 120, or like it's around from
Sorry?
100 to 120.
Yep.
Like the normal BP in an individual is 100 to 120. But why is it classified here as stage 1?
Okay, the average BP commonly is usually 120, within 110, 120. That's where the common average BP for an average physiologic human is forcing within 110, 120. Okay, some people will say within 100 and 120. However, why this is added is that shock is a process. It starts mild and goes to severe.
Here you go.
So in the mild form, you will see that BP is dropping. It's when you get to the severe form that it becomes very obvious. So before you, in fact, there's a saying that shock is a diagnosis of retrospect. In retrospect, just we label is a diagnosis in retrospect. That means by the time you have this, by the time you're making a diagnosis of shock, that patient has already had the shock before, has already had the shock ongoing. So to catch this shock, hence that in stage 2, stage 1, stage 2, stage 3, stage 4. You don't want the patient to get to stage 4. You want to catch the patient at best stage 2, or at best stage 1, or at most stage 2. Hence, there's a classification of stage 1, so that by the time you are seeing your BP dropping from, for instance, you check the patient BP is 120, it's now dropping to 110. Once it is increasing, you know you're already entering into stage 1 shock. You have to do something about it.
Doc, please, can you come again with the blood pressure for stage 1? Stage 1 is like 120, isn't it?
One is 100 to 120.
Okay.
The other one is 100 to 80, 80 to 60, less than 60.
Okay.
Are we okay?
Yes.
Okay, so the other they may give is urine output. The another option may give is urine output. You know, the ideal urine output is 25 to 30 mils per hour, right? Now, for the stage 1, which falls within 25 and 20. When you have urine output at 25 to 20 mils per hour, you know you're in stage 1 shock. When you start having a urine output of 20 to 15, you're in stage 2. When you start having a urine output of 15 to 10, you're in stage 3. When you start with less than 10, you're in stage 4. Okay, someone asked, is hemorrhagic shock and that for hypovolemic shock? The answer is no. Hypovolemic shock is a big heading that comprises hemorrhagic shock, fluid loss from vomiting, shock arising from vomiting, shock arising from diarrhea, shock arising from third place loss. So hypovolemic shock is a big term that tends to encompass everything that involves loss of fluid from the body that results into shock. That's hypovolemic. So anything that makes you lose fluid, be it blood, be it serum, or be it even water from your system, from via vomiting, via stooling. Anytime you lose fluid and that occurs and then the result of shock is classified as hypovolemic. So, however, this hypovolemic shock, there are different things that can make it happen, like hemorrhage, bleeding. And commonly, hemorrhagic shock bleeding is the commonest type of hypovolemic shock and is the commonest type of surgical shock. If you go to pediatrics now, the commonest type of shock will not be hemorrhage, it may be vomiting or diarrhea. You get? So that's why in surgery, if you use surgical test, we will focus more on hemorrhagic shock because that's the one that concerns us. If you go to pediatrics, we're talking about correcting dehydration because that's what concerns them in the type of hypovolemic shock that they encounter in their practice. So again, for the urine output, we give you a value in the range of 20 to 25, 20 to 15, 15 to 10, and less than 10. So the value of the urine output will tell you the stage of shock. Again, as I told you, they will not give you the entire 4 or 5 parameters. They may just give you 2 parameters only. Sometimes if the examiner is so mean, they just give you only 1 parameter. Right? From there, you will be able to identify the type of shock you are dealing with. Are we good? So these are the on that value they may give you is the respiratory rate. They can give you again, may give you when the respiratory rate is within 20 and 30, that's stage 1. When it's within 30 and 40, that's stage 2. When within 40 and 50, that's stage 3. When it's greater than 50, is stage 4. Are we communicating? Hello,
Look, please, the normal respiratory is 12 to 20, right?
Yeah, some will say 12 to 18, some will say 12 to 20.
Okay.
So once you get the respiratory within 20 and 30, you are dealing with stage 1. Once you get within 30 and 40, you're dealing with stage. For an adult, all these parameters I'm giving are for adults, not for pediatric baby. Once you get it within 30 and 40, stage 2, 40 and 50, stage Stage 3 and greater than 50, stage 4. Are we communicating? Now, the question that will come again, like, let me give you again, is that we give a patient that has had a trauma, maybe from an accident or a knife cut or a stab wound, then they will not give you one or two of the parameters. They cannot tell you what stage of shock is the patient in, what stage of shock is the patient currently at. Or they go also ask you to calculate the blood volume that has been lost. So if you look at the parameters, you could say, okay, for the parameters being provided, the patient is at stage 2 of shock. That will give you the answer. They will tell you what's the blood volume that the patient lost. Looking at the parameters, you then, okay, for stage 1 is 15 to 30% of the blood that has been lost. For stage 2 is 15 to 30%. And for stage 3 is 30 to 40%. For stage 4 is greater than 40%. Now, again, in the exam, they're not going to put a value that falls within 30 and 40%. They're going to put a value that's either 40 or 30%, or either 15 or 30%. Are we communicating? Are we communicating?
Please repeat.
Yes, please. Yes, please. Okay, so these percentages are the percentage of blood loss.
Yes.
In hemorrhagic shock.
Yes. So they either put 30 or 40 or 15 or 30, because they understand that the range is such that anything can fall in between. So they'll put a value that falls either within the upper limit or the lower limits. Are you communicating?
Yes, sir.
Okay, so that question that you're asking me, could you not ask again? Let me get the question properly now. Someone asked a question about this, and I told the person that when I finish to this stage, I can answer the question. Could you not ask the question now?
You already answered my question by explaining everything, like all the stages. Yes.
Okay, fine.
Yes. I'm sorry, I want to ask it another question.
Okay.
Let's just assume that we are doing MCQ now, and they now give us, let's say, in the MCQ, they're now giving us 15% and then 30% as the options. Which of them are we going now pick as the answer?
The examiner will not give it to you. He's going to give you one, and it's going to be either 15 or 30%.
All right.
Or either 30 or 40%. So going to give it to. I still going to give it in between.
Okay.
All the questions I have seen, it has not been in between. It's either on the lower margin or they give you on the upper margin. They don't give you in between. They don't give you both of them.
Okay.
Can we progress? So this about hypovolemic shock. That question they may ask you is that patient had diarrhea, this. What type of shock is it? Is hypovolemic shock? That's another question. That way they can ask the question to you again. Or the patient had typhoid perforation, was noticed to be having abdominal distension, and suddenly the parameters, you just give any of the stages of the parameter and tell what type of shock is this hypovolemic shock. You get. You will not see the stages. They will just put two types of shocks. You will see hypovolemic, cardiogenic, and the other ones hypovolemic shock.
Come again, Doc. You just mentioned, what did you just mention this last time? You said typhoid?
You said patient had maybe typhoid septicemia or typhoid perforation, right?
Yes.
I started noticing that the abdomen was distending. And suddenly the pulse rate increased. You put a value, the BP dropped, and you put a value, the urine output started reducing, they put a value. They will now ask you what type of shock it is. In that instance, you may not see the stages of shock. You may see cardiogenic shock, distributive shock, hypovolemic shock. In that instance, you answer stages to hypovolemic shock.
Okay.
You also see hemorrhagic shock also too. It's not hemorrhagic.
Okay.
For it to be hemorrhagic shock, there must be evidence of active bleeding.
Of active bleeding.
Yes, active bleeding. So if you don't see any question that says patient bled significantly or bled from an open wound, it's never hemorrhagic shock. It's hypovolemic shock.
So, maybe, Doc, eyes typhoid septicemia. How does it classify as hypovolemic? And abdominal distension.
Okay. How it occurs is that for type for to have abdominal distension, it's likely type of perforation.
Okay.
Maybe I may digress a little bit to be able to give you the explanation in which. But what normally happens is that in type of perforation, when there's a perforation, in the first instance, the intestinal lumen has bacteria that are kept in check because it's not communicating with the abdominal cavity itself, and it's not communicating with the blood system. So when there's a perforation, it simply means there's a hole between the intestine and the abdominal cavity. With that hole, bacteria is able to translocate from meanwhile, the peritoneal cavity is sterile in the normal standard temperature and pressure. That means without any breach, it's sterile. Once there's a breach, like a type perforation, the bacteria moves from the gut into the peritoneal cavity. And when it gets there, it stimulates inflammatory reaction. That inflammatory reaction leads to edema, opens up the cell adhesions, break it up a little bit open. Fluid flows into the abdominal cavity. That will lead to fluid pulling from the vessels into the peritoneal cavity. Also, too, again, intestinal contents are hyperosmotic. When they get into the peritoneal cavity, they also, because they're hyperosmotic content, they also pull fluid via osmosis into the peritoneal cavity. Also, to the intestinal content, particularly the juice, they are irritative to the peritoneum. When they get to the peritoneum, irritate the peritoneum, causes inflammation. That inflammation further weaken the membrane, cells and adhesions, allowing them to creating microscopic breakpoints where fluid is able to pull from the intravascular compartment to the extravascular compartment. And when fluid pulls into the extravascular compartment, what do you have in the intravascular compartment? You have hyperviscosity. With hyperviscosity, blood flow becomes sluggish. And when blood flow becomes sluggish, what then translates simply means that blood flow that's necessary to pull nutrients into the cell, that's necessary to move cells that carry nutrients into the cell and move those cells out to the lungs and to the kidney to deliver waste taken from the cells. That flow is slow and inhibited. What that happens is that once that flow is inhibited, not enough nutrient gets to the cells, and not enough of the waste product is excreted from the cells, and then shock results. Does it make sense?
Yeah, thank you.
Okay, so that's how that happens. So the fluid start pulling into the peritoneal cavity, and that pulling of the fluid now leads to abdominal distension. So can we now progress now? Okay, now on that we've talked about hypovolemic shock, right? A possible question that may occur in hypovolemic shock. On that type of shock that can occur is cardiogenic shock. Now, cardiogenic shock is usually, what cardiogenic shock simply means is that failure of tissue perfusion as a result of failure of the heart to pump blood. The heart is considered as a major organ that's responsible for pumping blood into the body, around the body. Now, again, for those that are preparing for primaries, I want to write primary surgery. You may see a question like this that's come out before. How many hearts do we have in the body? There are 3 hearts in the body. But this for Nigerians, so that I want to write Nigeria exam, it may not sit in foreign exam, or it may not sit, must not sit in MDCN exam, but it may sit in those that want to write primary exam in the future. There are 3 hearts in the body. The number of hearts you know, which is one that's in your chest, that's one you know. Yes, also is the soleus muscle is also considered as a heart, and the masseter muscle is also considered as a heart.
Oh, please come again with the muscles. Please come again with the two muscles.
Soleus muscle is considered as a heart.
Soleus.
In the leg, yep.
Okay.
And the masseter muscle is considered as a heart. Right? That's for those that want to write Nigerian exam. Yeah.
Please, can you spell the soleus? S-O-L-I-U-S.
S-O-L-E-U-S, soleus muscle, the gastrocnemius and the soleus muscle in the calf or the leg. And there's a reason why they say this muscle are heart muscle. Because what does heart do? Heart pumps blood into the circulation. And when these muscles contract, they help to pull blood upwards. So based on that, they de facto consider them as hearts. Yes. Now that
where's the masseter? Where's the masseter muscle located?
Is it yeah.
Yes. Okay.
Yeah.
Okay, for chewing. For chewing.
Yeah, that's masseter. So, but this is just an impromptu, a type of information that you may not need for your MDCN exam, or you may not need for your PLAB if you're writing PLAB, but you may need it if you're writing primaries for National West Africa. You may just see it, or you may encounter it if you start residency in Nigeria. You may encounter it when one of your lecturers may just ask you one day, what type of, okay, we agree. Heart, this, I mean, type of heart, okay, apart from the heart, which other heart do you know in body? You can just something like that, just come up and get. So, but that's by the way. Let's go back to our conversation. Cardiogenic shock. For cardiogenic shock, it's the heart in the chest that they are talking about, not also the two muscles. It's the heart in the chest they're talking about. And for cardiogenic shock, it is failure of the heart to pump blood effectively well. That is what causes cardiogenic shock. When the heart fails to pump blood very well, cardiogenic shock occurs. Now, having said that, how would this question come out? It may come out like, so patient was typing or doing something mild activity. All of a sudden had a gripping pain in the chest, or they say a squeezing pain in the chest. Question may come again that, okay, the pain radiates to the back, or it may tell it radiates to the jaw, or it may tell it radiates to the neck, or it may tell it radiates to the armpits, or it may tell it radiates to the elbow. Having said this, we will not tell you that the BP was noticed to be this. It will give you a BP that corresponds to any of those parameters I gave to you. So it's only BP less than 90 or something like that. And then they will not ask you what type of shock is this. The answer is cardiogenic shock. Are we communicating? Are you communicating?
Yes.
Or they may also ask you again that what possible cause would have led to this? The commonest cause of cardiogenic shock is myocardial infarction. So you will see something like peptic ulcer disease, you see something like cholecystitis, you see something like gastric C, they will not see something like myocardial infarction. You might be thinking peptic ulcer disease because, again, we also tell the patient had heartburn. Then the heartburn suddenly notice pain in the armpits or in the elbow or in the lower jaw or in the neck. They will not tell you that they may not give a BP that's maybe 90 or maybe 80 or 100. They will not tell you what is the commonest cause of this. You will see things because you hear heartburn and you will not be thinking is peptic ulcer disease. Once you hear pain that's referred to somewhere else, like the back, sorry, to the armpits, commonly if they put heartburn, they may not want to put back. They may just put the armpits, they may put the neck, they may put the jaw, they put the elbow. Once you see this referred pain with associated with heartburn, is myocardial infarction. Then they may tell you, okay, you may also ask what type of shock is this cardiogenic shock, right? Are we communicating?
Yes, sir.
Okay. Then they may also ask you again, I don't know if this particular part is is okay. We'll talk about that later. The commonest type of treatment that you may need for that, we'll talk about that later. So for distributive shock, what distributive shock simply means is that there's failure of, the problem is not coming from the heart, first of all, right? It's not coming from failures. It's coming as a result of failure of flow, primarily from flow of blood. The problem from flow can come from the heart, but this one, the heart is okay. The problem is intrinsically from the problem of flow. Example of distributive shock are septic shock, hemorrhagic shock, and obstructive shock. Obstructive shock is another part. Obstructive shock is on the point about distributive is septic and hemorrhagic shock. Sorry. So in distributive shock, the problem again I said is failure of flow. This flow is not coming from an obstruction, no, it's just failure of the vascular system to flow properly. And commonly, what usually will occur in this instance is that the vessels become dilated. Normally, for flow to occur, there's usually some level of tonicity. There are muscles in both the arteries and the veins, whether arterioles or venous. There's level of small muscles inside. Right? So usually for the arteries, the muscles are much. For the veins, the muscles are less. Now, this must be in some level of tone for flow to occur. But in distributive shock, that tone is lost in any form. And what differentiates the type of distributive shock is what is causing the loss of that tone. Are we communicating? Are we communicating? I want to be sure I'm communicating. Are we communicating?
Yes.
Yes.
Yes, sir.
Okay, so like I said again,
Yes, sir.
for distributive shock, what is causing the loss of tone is what is responsible for the distributive shock. Now, for septic shock, it's usually caused by microorganisms. For neurogenic shock, it's usually caused by the loss of autonomic reflex.
Urogenic.
Neurogenic.
Okay, neurogenic. It's caused by what?
Sorry?
Caused by what?
In neurogenic shock, it's usually caused by loss of autonomic reflexes. The autonomic reflexes, we have the sympathetic and the parasympathetic. The sympathetic is
in the blood vessels.
Tone. Sorry?
In the blood vessels.
In the blood vessels, exactly. So in neurogenic shock, that's it. First of all, in the autonomic nervous system, we have the sympathetic, we have the parasympathetic. The sympathetic nervous system, particularly, is responsible for the tone of the blood vessel. Right? Now, if for any reason there's injury to commonly the spinal cord, and then that supply, autonomic supply to the blood vessel is cut off, the tone is lost, you have neurogenic shock. Again, neurogenic shock is different from spinal shock. We'll talk about that when we will get to neurogenic shock. Because this thing, you will see that you see them in question a lot. You see neurogenic shock. When question for neurogenic shock, when you see spinal shock there too, to confuse you. They always come together. We'll talk about that when we get to neurogenic shock. But let's focus on septic shock, which is where we are right now. Like I said, in septic shock, in distributive shock, the problem is that the tone to the vessel is lost. What is causing the tone is not dependent on the type of distributive shock we are talking about. For septic shock, it's usually caused by toxins. Common cause of toxins are usually microorganisms. Right? In septic shock, again, the cause of the vascular dilatation by toxins, and the commonest cause origin of toxins are usually from microorganisms. Are we communicating? Are we
Yes,
communicating?
Yes.
How does this cells cause, how does this toxins occur? Usually from gram positive or gram negative. Well, of gram positive and gram negative, the one that causes the major effect is gram negative. I'll explain that as we go along. Perhaps we should also talk about it now. For gram negative, they have this cell wall. Their cell wall has the lipopolysaccharide, like lipid A, peptidoglycan layer, right? So the lipopolysaccharide particularly is the part that's very endotoxic in nature, and that's the part that actually causes, that commonly is more efficacious in causing the septic shock. So let's continue. Now, how does septic shock present? Commonly, the classical feature you get in septic shock is in the pulse rate. That's where you get to differentiate septic shock from the other type of shock. And commonly, the pulse rate is bounding.
The what? The pulse rate?
Is bounding. If you want to describe the other type of shock,
pulse rate.
Yeah. If you want to describe the other type of shock for you, to tell the shock is steady, the pulse rate is steady. But we don't tell you that the septic shock, you tell the pulse rate is bounding. That means if you feel it to be pouncing in your hand, boom, boom, boom. But for the other one, if you feel it, you have to press harder for you to even feel the pulse rate for the other type of shock. Are we communicating? We're supposed to spend 1 hour, was most spent 1 hour now, so I'll just try and round up. Okay, so for the other type of shock, the pulse rate is usually straight, but for septic shock, the pulse rate is bounding. So when you give a clinical scenario, the patient pulse, the BP is dropping, right? The urine output is dropping, but the pulse rate is bounding. Once you hear that bounding, or the pulse rate is heaving, once you see those things, yeah, that's totally about septic shock. Sometimes you want to help you make it, they even tell you that the temperature is elevated, right? Once you see that, you're talking about, you're dealing with septic shock. Or sometimes the examiner may be, be too happy and want to hide that. If it tells you that there's fever, you'll be tilting towards septic shock. You may want to hide that part of the information from you. But the information will give you that the pulse is bounding. Once you hear that pulse is bounding, or is heaving, or is hitting at the examiner's finger, that patient is having septic shock. Are we communicating?
Yes. Yes.
Okay. So, some of these from like I told you, you may not need them. So I will jump some of them and move on. Now, like I said again, in neurogenic shock, the problem is that the autonomic reflex that supplies the vessels have been cut off. It may be temporary, it may be permanent. And then commonly, when they give question on neurogenic shock, they will put spinal shock as one of the options. Because commonly spinal shock and neurogenic shock, they commonly have a common etiology. Usually, you tell the patient maybe was a driver, had sustained injury, and then they may now to confuse you and give you a features of spinal shock. That the patient at the point in time could not control his urine, he could not control his physics. So once you are seeing this, you are thinking spinal shock, right? They will not tell you that the pulse rate is low, the BP is low. Once you see this parameter, it's neurogenic shock. Now, what is neurogenic shock? What is spinal shock? Spinal shock is a period of quiescence in the spinal cord after an injury. That is spinal shock. It's period of spinal cord quiescence after it has been injured, where the spinal cord at the point that is not reactive. So in those instances, the spinal reflexes that normally occur, like if you want to urinate, you just feel like you want to urinate, you can't urinate. You want to defecate, you just feel like you want to defecate, you can't. All those reflexes that you have, that not you, that people have, will just be cut off. Yeah. So the patient may start having urinary incontinence, fecal incontinence, and co like that. Then the patient may also be paralyzed too. In those instances, that patient has spinal shock. It doesn't have neurogenic shock. If the vital signs have started being affected, the patient has neurogenic shock. Are we communicating?
No, Doc, please come again with the differences, please. The spinal shock, for example.
Spinal shock is not shock in the sense of definition of shock, right? Spinal shock is a term different from shock on its own. It's not shock as a topic. It's a misnomer. You get? So because it's a misnomer, examiners tend to mumble both of them together and give candidates.
Yes, in spinal shock, the vital signs are okay.
Obviously,
or could be okay. They are okay.
They're okay.
Okay.
But in neurogenic shock, the parameters are low.
Yes. Okay. When the vital signs becomes
starts changing downwards, you know you're dealing with neurogenic shock.
Yes.
So spinal shock does not have to do with anything vascular. It has to do with reflexes that the spinal cord controls on its own outside vascular control, such as urination, defecation, paralysis, and stuff like that. Are we communicating?
Yeah.
So once you see neurogenic shock, spinal shock, then they are giving parameters that are vascular. Please, they are dealing with neurogenic shock. But you see both of them in the option. So you'll not be confused. Spinal shock, neurogenic shock. Okay. Common cause of spinal cord and neurogenic shock. I see the same common cause of spinal shock. For instance, someone that has injury to the spinal cord, someone that has hematoma on the spinal cord. Okay. So both of them have almost similar etiology, but their presentation is different. And then what they mean is different. The spinal shock is a misnomer because it tends to give you a wrong impression of what they are talking about. Okay, so I'm coming. Okay, so this traumatic shock, I will jump that. I don't think you will need this. This may not come out to your exam, it's postgraduate stuff. For obstructive shock, in obstructive shock, there's a mechanical obstruction of blood flow. It's a mechanical obstruction of blood flow. Commonly, the common type of obstructive shock is usually tension pneumothorax and cardiac tamponade. For tension pneumothorax, what commonly occurs is that there's injury to the lungs, particularly to the pleura, that makes it communicate with the external environment. So once an injury that makes it communicate with the external environment, because the pleura is usually a negative pressure below atmosphere, it pulls it pulls air into itself. As it's pulling air into itself, it's shrinking the lungs itself. As it's shrinking the lung, there's, of course, patients having respiratory embarrassment. As it keep pushing air, it also keep pushing thoracic content to the contralateral side. But the pressure start building up inside, from negative become positive compared to its initial value anyway. Then, of course, as I keep doing that, it start compressing the lungs start shrinking. at the point like it start accumulating more space, start pushing the other structures in the thoracic cavity to the contralateral side. Hence, the tension pneumothorax, you will say that the trachea deviates to the contralateral side. This is how it happens. Okay. Okay. Are we communicating?
Okay, doc. Okay.
Sorry?
Yes, okay, doc. So for tension to happen, that means I say for the tension pneumothorax. So there's a communication with the external environment, right? So which pulls in air into
for
the pleura.
tension to occur, because they are simple extensions.
Okay.
For tension to occur, there's really communication.
Yes, for tension to occur.
For simple, there may not be
Communication.
communication yet. There are three types of pneumothorax. We have the simple, we have the tension, we have the open. But this is not topic for today, it's topic for another day. You get? Are we communicating?
Yes, please.
Okay, so for cardiac tamponing, what normally occurs is that just like tension pneumothorax, there's fluid buildup in the pericardial space. So that now further compresses the heart. First of all, the heart is suspended as lungs suspended in the pleural cavity. But in this place, the heart is suspended in the pericardial cavity. The pericardial cavity is formed between the visceral and parietal pericardium, just where the lungs and the pleural cavity is formed between the visceral and parietal pleura. The same thing occurs in the heart. That cavity is a potential space. A potential space simply means that the space is technically obliterated. It has minimal fluid, but has capacity to accumulate larger amount of fluid. That's a potential space. That means the space under normal condition is obliterated, having minimal fluid, very minimal, just to keep it patent. But that same space has the capacity to accumulate larger amount of fluid. That's the potential space. So the pleural cavity, the pericardial cavity, the peritoneum are potential spaces. So in cardiac tamponade, that potential space in the pericardial cavity start accumulating fluid. I keep accumulating fluid because the heart is a fixed cavity. The thorax is a fixed, relatively fixed environment. I keep accumulating fluid. It start compressing the heart. But the heart is only structure that can be able to accumulate, of all the structures there, it's not that can be able to accumulate stress and increase in volume. As it keep compressing the heart ability to pump blood, to receive and pump blood to the body diminishes. And when that happens, you have obstructive shock. Now that differentiates from cardiogenic shock. When cardiogenic shock, the pathology is in the heart itself. When cardiac tamponade, the pathology is not in the heart, but it's in the pericardial cavity. Are we communicating? Are we communicating?
Yes.
Okay, cardiac tamponade. Classically, how you identify cardiac tamponade is that they will tell you patient maybe was involved in, maybe it was a driver, had the chest hit on the steering, and then clinically, heart sound was listening, it was muffled and distant. There's distended neck veins. Then the vital signs are classical of a shock. The pulse rate is high, the BP is low, distended neck veins, muffled and distant heart sound. Once you hear muffled, distant, distended neck veins, hit the chest, you should be thinking of cardiac tamponade. They may just ask directly what was diagnosed with cardiac tamponade. They may ask what type of shock it is. It's obstructive shock. May also
Doc,
ask you again.
sorry.
Okay, I was saying.
No, yeah, please finish.
They may also ask you again. They may just jump after giving this clinical scenario. They may just jump directly and tell you, okay, what can you do temporary as a measure for resuscitating this patient? And what you do is you pass a needle 45 degrees at the sternal joint, angulate it to the clavicular joint, and drain fluid. That's a temporary measure pending when you do a thoracotomy. Only for this exam, they will not ask you about thoracotomy. You ask what temporary measure. You don't ever ask about management, whether in PLAB or USMLE. For USMLE, we ask you the other part which I just said. But for PLAB, we not ask. We just ask you what's the initial measure. For the MDCN, we ask what is the initial measure. So pass a needle at the ciphisternal joints, angulate it 45 degrees to the steno, what is not joint again? The acromioclavicular joint. Now, all this for which I just give you, they may just pick one of it. They may ask you how to angulate the needle 45 degrees. They may also ask you how would you point towards acromioclavicular joints. These are the possible ways the question could come out from. It mustn't be that you must speak the entire options. What are the possible ways they could show the question as shown?
Sorry, you say it's which joint? Acro what?
Acromioclavicular. This is the clavicle.
Okay.
This is the acromion. So these joints here, if you touch it, you'll feel it here. This joint. So you angulate your needle from, you can directly, angulate from your chest, directly towards this joint at 45 degrees. If you do that, you're able to get to the pericardial space. And once you start seeing blood, you stop. You move your needle, you leave your trocar inside, and you connect it back to it to drain the blood. That's a temporary measure, it's not a permanent measure. Why is it temporary measure? Because that blood will clot as soon as it comes out. With time, it's clots. Sometimes there are already blood clot in the pericardial cavity. Though the pericardial cavity will not contain blood, but when the bleeding is too much, it will definitely overwhelm the antifibrinolytic effects in the pericardial cavity, and they will clot. That clot may block the needle, or it may not be able to pass through. So the definitive treatment will be thoracotomy. Are we in the same page?
Yes. So this tension pneumothorax, how does it cause shock again?
Okay, how it causes shock is that once the tension start building, right?
To the contralateral side of the heart.
Sorry? Could you come
the tension pneumothorax?
Okay.
The tension pneumothorax, how does it cause obstructive shock again?
Okay. So how it causes obstructive shock is this. As the tension start building in the chest, right? It pushes every other structures, including the heart itself, or the trachea is on the contralateral side. As it's pushing it, so that pressure is also affecting the vessels also, like the superior cava, inferior vena cava also too. And it's also compressing the heart to the heart itself. As will not be pumping effectively very well.
Okay.
Second, that pressure is also inhibiting blood from the SVC and IVC from getting to the heart also too. Again, it's also affecting that lung, inhibiting adequate oxygen. So if you're not taking adequate oxygen, you cannot give oxygen to the tissue. You're not adequate camouflage, you can't export metabolic waste products. How are you communicating?
Oh, Doc, you said how does it also affect the lungs? Say it after the deviation, right?
Lungs,
also
as the pressure is increasing, is compressing that lung starts shrinking.
Yes.
So for instance, you have two lungs that gives you oxygen properly well. That one of that lungs starts shrinking and becomes ineffective. You have one lung, right? So that means if you have 2/2, you now have 1/2, have you?
Okay.
And that other lung that you have contract that is not affected is also now being compressed again. So you now have 1/2.
Yes.
Yes. Sure.
Yes.
So initially you have two lungs that are normally.
Yes.
One of the lung now is compromised. You are going to have that will compensate for the one that is compromised. It's also being affected by the pressure that automatically oxygen
Someone is making it impossible for us to hear.
Oh, sorry.
There's noise at the
If
background.
I can see the person, maybe I feel the person.
Good afternoon, good morning. Hold on, my how's work? Hold on.
Okay, so that's for obstructive shock, right? So now let's move now, right? Like again, some of the common causes of shock again. This I'll just scan through this: fracture, blunt thoracic injury, penetrant, UTI, bleeding, prostate, bleeding. You could just look at it. If you have any question, ask me. I will explain how they all occur. If you want, if you need me to explain them to you. Otherwise, I will just move through. So I'll just give like 1 minute for people to just glance through this page. Some of the causes of shock. So let's move, right? So that's more the other possible causes of shock again. Okay, pathophysiology of shock. Again, this slide just gives you basically a preamble of how shock occurs. Whatever is the cause of the shock, whether it's from hypovolemic, from cardiogenic, from obstructive, from distributive, or from traumatic, the underlying driving factor is that there is decreased cell perfusion. That means decreased blood supply to the cells itself. And of course, with that decreased blood supply, there's decreased oxygenation, there's decreased removal of waste product metabolism. Now, once there's decreased oxygen, there's first of all, let's look at it in this context. You need 10 naira to transport yourself from, let's say area 1 now, let's say to Beggar. You need 10 naira. And then you only have 5 naira. Automatically, you're in deficit of 5 naira. It simply means that that car was not, that 5 naira was not be able to transport on a car to from area 1 to Beggar. That's for those that live in Abuja anyway, if you understand. Now, that's exactly what happens in the cellular level. Once there's a deficiency of this, once there's poor perfusion. Sorry, let me be the same person. Once there's poor perfusion, right? So once you are trying to move from Beggar to area 1, and that cost is 10 naira, you only have 5 naira. Automatically, it means you may have to transport yourself to have the journey and find another means of getting to Beggar. Either you trek, you run, or you look for a lift, or perhaps you use a bike or something to get to Beggar. That's exactly what happens in shock. So once there's decreased perfusion, there's decreased oxygen supply, there's cellular deficit. That means the body requires, let's say 40 ATP. Let's say the cell requires 40 ATP to survive. And then the amount of blood that is getting to it can only supply 20 ATP. Automatically, the body will have to find another means of generating that, at least if not 20 ATP, at least maybe 10 ATP. And that means of generating that ATP, extra ATP, is what now result to the problems that occurs during shock. And now the magnitude of that the magnitude of the degree to which the consequences occur when the body is trying to find a way of generating that extra ATP depends on the amount of blood it gets. That means if someone has 5 naira and wants to go from area 1 to area 3, it means you have to stop halfway and check halfway, or You have to stop halfway, check halfway, find on that means halfway. But if someone has 7 naira, he may have to transport to third the way and maybe trek 1/3 the way. It's the same that happens here. So if someone has average blood flow, the magnitude of the effect from the body trying to find the alternative means of generating energy will be less than someone has lesser blood flow. I don't know if I'm communicating. So
Yes, please.
okay, so and how the body try to find a way to circumvent this decreased blood flow is simple. It's one, shutting down some part of the body that require lesser blood to other areas that require much blood. For instance, the heart requires much blood, the brain requires much blood, the kidney requires less blood, the intestine requires less blood, the muscles require less blood. So once you have a deficiency, the body now switches up, okay, now I have to compensate for this 10 ATP I need to. So, okay, now kidney, I will, before you used to take 2 naira, now I'll give you 1 naira. For instance, kidney, let's say you take 2 liters of blood per minute, I will now give you 1 liter of blood per minute. Intestine used to take 1.5 liter of blood per minute, now I will now give you 500 blood per minute. Muscle used to take about 1 liter of blood per minute, now I will now give you 200 blood per minute. Brain, you cannot survive without oxygen, without blood though. I will now, this blood, I'm able to mop up from all these places. I will now give it to you so that you can survive. Heart, you cannot survive without blood though. So this is that blood I'm mopping out from this other place, I'll give it to you so that people can function. Because if people don't function, we cannot survive. You know, say, okay, fine, I can manage pending when this problem is resolved. Anytime we say I can manage pending when this problem is resolved. Most will say I can manage pending when this problem is resolved. I don't know if I'm communicating. Am I
Yes.
communicating?
Yes.
Okay.
Yes, sir.
Okay, fine. Having stifled the body from all this, how does the body now try to make sure that this blood goes to the kidney, sorry, goes to the heart, goes to the brain, and less to the kidneys, and less to the intestine, and less to the muscle? It is via some mechanisms. And the mechanisms that this thing occurs, right, are basically the sympathetic mechanism, the adrenal mechanism, and then the hypothalamic mechanism. So for the sympathetic mechanism, what normally occurs is that, okay, the body has, okay, the brain has to take much blood, the kidney will take less blood. I will stimulate contraction of the arteries that goes to the kidney higher. When I stimulate contraction of the vessel that goes to the kidney, less blood will flow there. So if less blood flows there, more blood will flow to the brain. If you send that same signal to the intestine also too, I was stimulate the contraction of the arteries that supplies that to the intestine, the muscles, and some other organs of the body. Another means it does again is through the adrenal gland. In fact, the adrenal gland is usually the first to even respond to the early stages of shock. And the ones that will first release the catecholamines, the adrenalines, and the noradrenaline, particularly the adrenaline. The adrenaline will go and again cause vasoconstriction of these renal arteries, intestinal arteries, arteries that supplies the muscle. When they are contracted, less blood goes to them. Then the sympathetic system also further come again and then further cause their contraction, so that more blood will go to the heart and more blood will go to the kidney, so to the brain, so that the brain can function, the heart can function, while the patient maintain a basal metabolic rate, depending when the body is able to sort out these problem, whether it's whether from the heart or from the losing of blood, from diarrhea, or from vomiting, or from tension pneumothorax. So when this happens, another means again that the body tend to use to solve this problem is through the renin angiotensin aldosterone mechanism. What might happen as soon as the kidney senses that, okay, they've started me of some blood, at this point in time, I need to help the brain, because it means that the brain is suffering. Okay, I will not secrete renin. So renin secretion usually occurs as a result of when the kidney, when the afferent arterioles senses diminished blood supply. When it senses diminished blood supply, it then stimulates renin secretion from the juxtaglomerular cells. Juxtaglomerular cells, they are a group of specialized cells found in the kidney and the kidney has nephrons, right? So the nephron has different parts. When we get to that kidney section, we'll talk about it properly. But they are found around the nephron region between the am I debating now? Okay, when we get to that point, we'll talk about it. But then the afferent arteries sense that, okay, they reduce blood supply to me now. So I will not stimulate the juxtaglomerular cells. The juxtaglomerular cells now release renin. Renin now will now enter the bloodstream. On its own again, you can see cause vasoconstriction to all this other part of the body. But most significantly is that it does stimulate conversion of angiotensinogen to angiotensin 1. Angiotensin 1 is not as potent as its breakdown product, angiotensin 2. And this conversion to angiotensin 2 occurs in the lungs, particularly, and less in the liver, by what we call angiotensin converting enzyme. And this is where some drugs for hypertension comes in to tackle this enzyme so that, and therefore controls hypertension. So when SNAP converts from angiotensinogen to angiotensin 1 to angiotensin 2, angiotensin 2 is now a potent vasoconstrictor, very potent. It further can cause further constriction of these vessels, the renal, the intestinal, the muscle, and any other vessels that the body considers as less significant at that point in time. Having caused contraction of that stuff, there will be increased peripheral vasoconstriction. This is a temporary measure. So if the body is able to sort out its problem, like when this doctor realizes that there's shock and start giving fluid and start correcting what is causing the shock, the extension pneumothorax, pass the chest tube, or convert to simple pneumothorax, then pass the chest tube. Eventually, everything will resolve on its own. But if, for whatever reason, the shock still persists, that's when you're now going to the other stages of shock: stage 2, stage 3, stage 4, advanced stage, and the late stage. Now, if this problem persists too long, it's like, for instance, now you have to trek from area 1 to, halfway from area 1 to Bega, you have to trek that way. But for whatever reason, the sun was too hot, there was traffic, then there was amber on the way. It now took you extra time. You could not even get to the area 1. This problem. And perhaps you are going to get an interview or something. You couldn't get an interview, there's chaos. That's exactly what happens here too. So if for any reason the body could not sort out what is causing that shock, either the doctor could not identify it or he corrected it too late, then problems start occurring. For instance, the intestine, once there's one of the problems that will start occurring is usually will come from the intestine early. What normally will happen is that intestine normally the intestine itself has bacteria in it, has microorganisms. I won't say bacteria. Bacteria is just one. It has multiple organisms, but the common ones are the bacteria that are there, or the most prominent ones are the bacteria that are there, living their normal lives. And their life sometimes helps us. For example, they help in providing vitamin B12. They are living their life, they are metabolizing, and some of their metabolism include vitamin B12. And we need those vitamin B12 for our health. So it's like the body is living in symbiosis with this organism. The organism is feeding on what we are eating. We, at the same time, are not complaining because they're also giving us some other things that we need, like vitamin B12. So both people are just living on their own. Nobody is fighting each other. They are just there on their own. And then this blood supply that normally supply that will help this bacteria to supply their stuff is cut off. Or sorry, this blood supply that will carry things like white blood cell, macrophage that will prevent these bacterial cells from breaching their boundaries and coming to the bloodstream is cut off because the blood supply has been drastically reduced or shut off. Something in very severe case, even shut off completely. In my case, reduced. Bacteria was okay. The policeman that was guiding this person has gone away. No soldier, no police. Let's enter area. Bacteria will not translocate into the bloodstream because there's no more policeman that will, or no more traffic order that will say, okay, everybody enter this train. Nobody should be driving anyhow. All these people have all gone. So the bacteria will not translocate into the bloodstream. When you get into the bloodstream, it starts proliferating. The bloodstream itself is a culture medium. It has a lot of red blood, a lot of glucose inside. So this bacteria that was living comfortably on his own in his 2-bedroom flat, any salary of every month, living comfortably there, all of a sudden now entered CBN, and no security there, no CCTV, nobody there. Now saw billions. You will just start eating, stealing, calling all your family members to come. Oh, there's food here, there's food here. You start moving into the bloodstream. And when they start moving, they start proliferating, they start reproducing, and then they will not food the bloodstream, and they will not cause sepsis.
Doc,
yeah,
sorry, I was logged up. We stopped at this Renin RAS system.
Oh, we'll go for. Okay, let me.
The RAS. You were done with the RAS actually, so I don't know the next thing. You talk about.
I said after the RAS, what then happened next is that I was trying to explain how the shock progresses.
Okay.
That if when the RAS comes in to come and help to solve the problem, to provide more blood to the brain, and has that patient can keep, the individual can keep the better metabolism going.
Yeah, because the angiotensin 2 is a very potent vasodilator, vasoconstrictor. Yes.
So if the body is able to sort out what caused the shock, for instance, the patient presents to the hospital, doctor identified that the patient is in shock, and maybe it was from tension pneumothorax, and then correct the tension pneumothorax by passing a chest tube. Or you discover that it was from hemorrhage, patient was bleeding, secure the bleeder, transfuse the patient. Or the patient was vomiting, and then, okay, patient vomiting, give IV fluid. The body is okay, fine, the solution has come to everything will go back to normal. But if things keep progressing and then nothing is done, at the point in time, the body defense mechanism will be breached. How does this breaching occur? Commonly, you start from the intestine. I said again, the intestine has a lot of bacteria, and the bacteria is not doing us harm. We're not doing the bacteria. We are living in happiness with each other. But the bacteria is giving us things that we cannot produce. For instance, vitamin B12, we can't produce vitamin B12, but the bacteria can give us free of charge. And the bacteria feed from us, the food we eat, they eat from it too. So they are living peacefully, we're living peacefully. When they become too much, you have to find a way of following the physics and coming out. So everybody's living in harmony. There's no overpopulation there. And what usually happens is that sometimes there's also policemen in the intestine called the macrophages and the neutrophils that prevents the bacteria from crossing the intestinal lumen into the bloodstream. Of course, policemen need shift now, so they'll be shift with time. Periodically, they will have to replace them. New ones will come, old ones will go, old ones will die, new ones will be born, like that. So those defense mechanisms by macrophage, lymphocytes, and neutrophils, they come and they go. But when they come, they take their position and prevent the bacterial cells from entering the bloodstream. But once this cause that leads to this renin-angiotensin, aldosterone, sympathetic adrenal axis to cause vasoconstriction and last for too long, too much, no adequate blood will come to the intestine. So those macrophages that are there, they will not have food to eat in the first instance. They'll go weary, become weak. Some of them will even die. Some of them become incapacitated. And once you don't have a defense, if you don't have policeman guarding the bank, anybody that mistakenly enter the bank and so that everywhere is free, we go and call these people, oh, there's free money, yo, I saw money, come, let's come and pack. So the bacteria, once they feel that they see that, okay, there's the defense mechanism of this that keeps us in check had been breached, they find their way into the bloodstream. And when they enter the bloodstream, what do they see? They see enough glucose in the bloodstream. They see enough red blood cells like speak. That's hemoglobin in the bloodstream. You go and parasite on these blood cells. And when they start feeding on it, they'll start calling more, they start reproducing there. Of course, other microorganisms will start moving in also too, and they start reproducing, start coming more colonies. This will now further spread into the system, causing sepsis. So commonly, the terminal stage of shock, in any type of shock at all, is sepsis. Once you start getting towards sepsis, the patient is going to die. 98%, no, 90 is much. Usually 50% of the time, patient is going to die.
How many percent?
50%. The literature says that 50% that gets to ICU with septic shock dies.
50%.
Yes, that's what the literature, 50%.
Okay.
Okay, so that's how this story goes in. So septic shock can occur on its own. That means not from this pathway, but in any other type of shock, if you like to progress, to eventually lead to septic shock. Are we communicating?
Yes.
Yeah. So septic shock will just occur because the patient has urosepsis. It will occur on his own without, say, there was bleeding or there was cardiac failure or something. But any other type of shock that will occur, if it's allowed to progress, will eventually lead to septic shock and patient will die. So that's just the pathophysiology of shock explained. So this one just showed you the various trigger points. Hypovolemic shock usually decreased blood volume. For distribution shock, usually from severe vasodilatation, lead to decreased tissue perfusion. For obstructive shock, mechanical obstruction. This just showed you how it all starts, but they all get to septic shock eventually. So I just explained it now. Yeah, this slide just explain, divide into 3 phases: mid phase, middle phase, late phase. When it gets to late phase, patient will ultimately die. So the aim is to prevent patient from getting to late stage. So patients in middle phase, move patient from middle phase to early phase. Patients in early phase, move patient out of shock immediately. So that's the aim. So this all I've just been saying are details, micro details, which I feel you may not really need for.
Doc, the slide before this one, please. The slide before this one.
This one.
Okay. Yeah, thank you. Thank you.
Okay, so we can move. Okay, so this is all I was saying all this while. But this one is a little bit more detailed. Yeah. So this you consider that the bacteria multiply with less inhibition, with the level and blood. So this explains how it goes in. Yeah. So all this, you may not need all this. What you may need again that may come outside in your exam is this tumor necrosis factor alpha. It may come outside, but it's very unlikely it's going to come outside. It's going to come outside in terms of fever. How do you ask is that which of the following can cause elevated? It can reset the thermoregulatory and set points. You commonly tumor necrosis factor is one that will do that. Interleukin 1 will do that also too. You see that in your you can see that in your MCQ. That's how you're going to come as like one. But all these little details as postgraduate, you may not need all these ones. So this is all the fields of shake. Okay, so let's just talk about the current management of shock. This is just brief. I won't go very detailed. Now, the current management of shock is to prevent shock. That's the current management. Your aim is to prevent shock. And how do you can achieve that by taking good history and examine the patients. History involves assessing the patient nutrition, the blood level, correct any anomaly. So I'll just move on. But just know that the current management is to prevent shock. That's the current aim. Then once shock has occurred, the next thing is to institute therapy immediately. And your aim here is to correct the blood volume immediately and give the patient enough adequate oxygenation. How do you correct the blood volume? Correct the blood volume by giving fluid. That's the primary thing you do. In some, if it's from hemorrhagic shock, you give blood. In other shock, you give fluid. The one it is cardiogenic shock, you give cardiac stabilizers in addition. Then if it is septic shock, you give vasoconstrictors, such as adrenaline, that dopamine, dobutamine. All this stuff, I think they are a little bit high, so I'll try to avoid all this information. So that will be
okay. If it's cardiogenic, you give cardiac stabilizers.
Yes.
In addition.
Then also there's once you think that the common cause of MI is usually an embolus. So there's good standards to give is a catheter stenting. You see that what is the name for it? I can't remember the name right now. But it's a catheter stenting. You pass a catheter through the coronary artery, identify the point of or the point where the vessel is blocked, push the catheter through it, then you open the stent. So you're going to dilate that part that is constricted, and the stent is the job is there to create a channel for the blood to continue flowing again.
So what about the slide before this one?
Which one?
The slide before this one. Okay.
This one.
Yes, thank you.
I'm trying not to go to
the one before.
This one.
Oh, okay, thank you.
Okay, so that's basically, I won't go through all this investigation. This may not be, this may just be above what is required. Okay, so that coronary artery bypass grafting. So that this is it, but the best one is what I described for is percutaneous transluminal coronary angioplasty. That I described for you for the cardiogenic shock. Percutaneous transluminal coronary angioplasty is the treatment of shock for cardiogenic shock. So when it's cardiogenic shock, the catheter, you pass catheter. The catheter usually has a stent on the tip. You pass it through the coronary arteries, identify where the clot is. The clot may be fibrous, so maybe fatty, maybe commonly usually fatty clot, or maybe blood clot, but commonly usually fatty. Pass it, identify the clot, pass it through the clot to pierce it. And once it gets between the once it gets into the clot, you then open the stent. Once you open the stent, you take your catheter. The stent is non-deflatable, so you just open the vessel, blood start flowing.
Give me.
So can we move on? So that will be basically it. So thank you very much for today's lecture. So is there any question you want to ask? Anyway, this stuff is recorded. We may sorry?
Please, the previous slide, the previous 2 slides, please.
Okay, this slide is recorded. There's a possibility we may place it on YouTube so that you can go over it when you want to. Yes.
The one before this
Okay,
one.
someone said recorded class. Yes, for this question, someone said, sir, my internet is bad. I wanted to find out if we can get the recorded class today. There's a possibility. We are looking at placing this lecture on YouTube. So if we succeed in it, we would like to tell you the place where it is in YouTube. Okay, is there any questions someone to ask? Okay. Okay, so let me stop recording now.